When it comes to exploring the frontiers of space, sending a mission to moon, we are topping the chart. But what about our insights to our own heart, something closer home? Ladies and gentlemen, esteemed viewers, welcome to a captivating exploration of the groundbreaking frontier in cardiac health, and that is genomics in cardiac health, latest advancements and preventive measures. I am Nutan Manohar, adjunct faculty at the IIMK, guest lecturer at JIPMA, and various other institutions, founder of Me. And on behalf of Times of India, I extend a warm welcome to all of you as we gather for the Times of India World Heart Day Symposium 2023. Every beat counts. Genomics in cardiac health means studying your genes to understand how they affect your heart. It helps identify your risk for heart problems and suggests personalized ways to keep your heart healthy. With genomics, doctors can find out if you're more likely to have heart issues based on your genes. They can also give you advice very specific to you on your diet and lifestyle that matches with your genetic makeup. Sometimes they can even fix certain heart problems using special techniques. It's like having a health plan made just for you, and it can make your heart stronger and happier. And for this discussion, we have a panel of esteemed experts. We have with us Dr. Vedam Ram Prasad. Dr. Vedam Ram Prasad is the CEO of MedGenome India. He's a scientist with several peer-reviewed publications to his credit. He has been with MedGenome since its inception, and he spearheads operations and strategy. He has been a prime driver in building diverse genetic testing portfolio MedGenome offers. His commitment to adhere to the highest quality standards and processes has been instrumental in obtaining a CAP accreditation for MedGenome. With over 2 decades of experience, Dr. Ram was previously associated with Vision Research Foundation, Shankar Nethralaya, Spinco Biotech, and Genome Labs. He holds a Bachelor of Science from Osmania University, followed by a Master of Science in Human Genetics and a PhD in Medical Technology from BITS Pilani. Thank you so much, Dr. Vedam, for joining us.
Thanks, Nathan.
We also have with us Dr. Rajiv Gupta. He's a researcher, preventative cardiologist, rehabilitation specialist, and a consultant physician, and has over experience of 44 years in these fields. He's a pioneer in coronary heart diseases and hypertension epidemiology in India. He established the first cardiovascular epidemiology research laboratory in the non-governmental sector in the country. He chairs the Medicine and Preventive Cardiology Department at Eternal Heart Care Center and Research Institute, Jaipur. He is currently the president of Indian Society of Hypertension and convener of Prevention Council of Cardiological Society of India. Previously, he has worked at Cornell University, New York, and Hammersmith Hospital, London. Thank you so much for joining us, Doctor. And we also have Dr. Manish Bunel. He's a Senior Director of Clinical and Preventive Cardiology at Medanta, the Medicity, Gurgaon. He has been trained at premier medical institutions in India and abroad, including the All India Institute of Medical Sciences and the Princess Alexandra Hospital, Brisbane, Australia. Dr. Bansal has had an illustrious academic career with several gold medals and recognitions to his credit. Over 20 years of experience in treating all forms of cardiac illnesses, he's a recognized expert in the field of early detection, prevention, and management of coronary heart diseases, the leading causes of death in our country. Apart from his clinical experience, Dr. Bansal is an avid researcher and mentor to students undergoing training in cardiology and echocardiography at Medanta, and regularly invited faculty at various national and international meetings. And with that, I would love to dive right into the topic. Dr. Vedam Ram Prasad, genetic components are found in which common cardiac ailments? Is there a genetic predisposition for individuals to have cardiac diseases?
Yeah, thanks, Nutan. And I just recall the profound statement given by Professor Paul Berg, a Nobel laureate, several years back. So he said that almost every disease in humans has a genetic background or role played by genes. But depending upon the disease, the genetic component varies, and we call in scientific terms, it's called heritability. There are diseases where 100% cause is because of genes or changes in the genes that happen. We have certain common diseases where genetics plays some amount of role, maybe 20-30%, and lifestyle and environment plays a significant role. So depending upon the disease, it varies. And there are certain diseases where predominantly genes play a role. For example, there is a hypertrophic cardiomyopathy, which is a genetic disorder. There are what we call cardiac channelopathies, which is a genetic disorder. There are certain arrhythmias where genes play a critical role. And these are some of the common genetic diseases where predominantly the changes in the genome cause these diseases. There are certain congenital heart anomalies, if not all of them, where there are significant changes in the genes that cause, and environment plays a much lesser role.
Thank you, Doctor. That's really, really insightful. With that, I think I'll have a question for Dr. Rajiv. Dr. Rajiv, how does genomics play a role in common cardiac diseases like CAD, coronary artery disease, or myocardial infarction, or as we call it, heart attacks, where the onset is for the young? So young people having all these onsets, is there genomics playing or genetics playing a common, underlying factor?
Yeah, that's an interesting question. Many years ago, when we did not have insights into risk factors, all of our older clinicians used to think that family history or genetics is one of the more important causes. But then beginning from 1960s, we had new risk factors like high blood pressure, high cholesterol, diabetes, smoking. All these came into the picture, and the genetic things went into the background. Only in the last 10 or 15 years, since there's been a revolutionary rise following the DNA human genome identification and DNA mapping, there's been a significant rise in the interest in genetics. Now, this genetics is two types, as Vedam just said. One is the unipolar or monogenic disorders, which are single gene disorders, like cardiomyopathies, and even there is a disorder known as familial hypercholesterolemia, which is a high cholesterol, which runs in families. It's a homozygous familial hypercholesterolemia, where they develop cholesterol deposits very early in the arteries, and by the age of 10 or 15 years, children get heart attacks. But then the common form of hypercholesterolemia or high cholesterol is heterozygous, which affects almost 20 to 30% of the population. And then there are certain other conditions, like, for example, diabetes, hypertension, obesity, even metabolic syndrome, have certain gene component. So there is a very complex interplay of risk factors which are environmental, like pollution, like smoking, like unhealthy diets, and then there are risk factors which are genetic. So this is a gene-environment interaction, and a common disease like coronary artery disease has both the components. Now, this is important to realize because the risk factors such as diabetes or high cholesterol or high blood pressure work mainly in older age. At younger age, we have a different kind of pattern that we see in our practice. And the commonest pattern is that these people have a strong family history of premature heart disease. That means heart attacks occurring at the age of less than 50 years in their parents. They also have in themselves heart disease occurring at the age of less than 50 years. And then there are certain genetic components. Now, genes, they are not a single gene, they are multiple gene disorders. So we call them polygenic disorders, coronary artery disease, because multiple genes are involved. But now with technology available, we can do genome-wide association studies, which we talk later on, which can identify a risk of premature atherosclerosis. And there have been recent studies that at least in South Asians, in Indian people, almost 10 to 15% of risk beyond standard risk factors is gene driven. So I think genes are important in premature coronary artery disease. And if you look at only genes, you don't look at any other risk factor, almost 50% of the coronary artery disease is gene driven. So I think all the risk factors are driven by genes, like hypertension is driven by genetics, diabetes is driven by genetics, cholesterol is driven by genetics. And you combine all of them together, it's a very important message to realize that in premature heart disease, genes are important. So everybody has to be aware of their family background, the family history, and take into consideration.
Thank you, doctor. That is definitely important for all of us to understand that, especially with the high incidence of young onset heart attacks, it is very important to understand that yes, genetics has a role to play. So it is important to screen and understand. And likewise, there are environmental factors and lifestyle factor. Sadly, it is often a combination of all the three. And if we have greater awareness, there can be much that can be done about it. So thank you so much, doctor. At this point, Dr. Manish Bansal, when it comes to genomics, what DNA screening tests are available for heart conditions in India? How does genomics help in early detection?
You see, as Dr. Ramprasad and Dr. Gupta mentioned, that there are many cardiac conditions which have genetic basis, and all these conditions can be diagnosed by DNA screening. They mentioned that the diseases can be categorized broadly into two groups: monogenic, where there is a direct association between genetic abnormality and the disease, and there are many diseases. The common ones are heart muscle disorders like hypertrophic cardiomyopathy and dilated cardiomyopathy. Then some cholesterol abnormalities like familial hypercholesterolemia that Dr. Gupta mentioned about. Some rhythm disturbances, heart rhythm disturbances. Then diseases of aorta. Aorta is the main artery which comes out of the heart and supplies blood to the whole body. So these are the common monogenic diseases, cardiac diseases, which we can diagnose using DNA screening. And now with the advancement of genomics, we have been increasingly focusing attention on other diseases like CAD, coronary artery disease, diabetes, and hypertension, which have polygenic inheritance. So in them, by doing genetic screening, we are not going to diagnose the disease, but we can diagnose the risk of developing disease caused by genetics. So these are the two main strategies for genetic screening in patients for cardiac diseases.
Thank you, doctor. So in short, there are some diseases that are purely genetic in nature, and you can easily identify them through DNA screening tests. And some of the tests can actually indicate whether you have a greater propensity for specific other diseases as well. Thank you so much, Dr. Bansal. At this point, to Dr. Vedam Ram Prasad, when it comes to preventive measures for healthy hearts, are there any insights from genomics?
Yeah, so to reiterate, for those diseases where only genes play a role, monogenic diseases, it is becoming slowly as a first either screening or diagnostic test where you do a genetic test. It could be a DNA sequencing based test or any other simple PCR based test, where you try to identify any mutations are there that in individual, and you accordingly do what we call cascade screening in the family and either prevent or manage it better. There are certain treatments that are coming up based on what kind of genetic mutations are there. But if you ask in the larger group of diseases which impact the population much bigger, some things like coronary artery disease or myocardial infarction, diabetes, there is a new way of identifying, we call as polygenic risk scores. This is still evolving. The science is becoming more and more mature. Compared to last 5 to 6 years, there's a lot of new thought processes come, new way of identifying this risk or quantifying this risk has come up. But as we talk in the next couple of years, this will become more and more mature science and better science. We call this as a polygenic risk scores because, as Dr. Rajiv mentioned, there are many genes and variations across the genome which play a significant role. So they all have a modest effect, but all put together, you quantify them into a risk score, and you identify an individual whether they are at a higher risk than the average population or they are at an average risk of the population. And those individuals who are at higher risk, they can be put on active surveillance or sometimes even medical management. There are certain studies which have shown, on longitudinal studies which have shown that the medical management on the individuals who have a higher risk are more beneficial compared to individuals at average risk. And not only that, stringent lifestyle interventions can be done on these individuals to either mitigate the risk, because at this point of time you cannot modify the genetic risk, but you can modify your lifestyles, modify the environment, which can include your obesity or diabetes or the food you eat, the diet you eat, or the fitness, the physical activity, all these things, and mitigate the genetic risk so that the overall risk is significantly reduced.
Thank you, Dr. Vedam. I think the whole idea is, overall risk being significantly reduced. So thank you so much for that. Let's hope that more and more people opt to get themselves screened so that they can understand that, what are the diseases that they might be liable to and how do we prevent them so that they don't have to go through the pain of the disease. So thank you so much there. And Dr. Rajiv Gupta, when it comes to genetic heart conditions, which we touched upon, can they be treated, and how has genomics played a role in treating genetic heart conditions? So first one being, can genetic heart conditions be treated? And the other one being, how has the advancements in genomics helped us?
So there are monogenic disorders, we just talked about them. Most of them are very rare diseases. Of course, myocardial muscle hypertrophy is a common disease, cardiac hypertrophic cardiomyopathy or other types of cardiomyopathy, specific types. So number one question is, if we see a patient of this type, can we diagnose genetics or gene abnormalities? Now, we don't know everything about them, but we know lots of things about the monogenic disorders. We know what gene causes them. And there have been trials, although in a very early stage, first in human trials, especially focused on cardiomyopathies or channel disorders, which have tried to give some sort of gene therapy. And then there are techniques, there are 2 or 3 major techniques. One is a cell-based therapies that you inject healthy donor cells from somebody else which have the protective genes, and they may improve it. But that is a very sort of a old-fashioned technology. The newer technology is you could devise this known as CART or CART technology, which is also evolving and improving the type of treatments for these diseases. But I think the third and the most important thing is also important, that if you identify a particular gene disorder, you could develop some proteins, some monoclonal antibodies, some immune-mediated salts, both large molecules and small molecules, which can neutralize that particular gene. A very good example in field of cardiology is the PCSK9 inhibitors. Now, it's only about 15 years ago that the first report came in that PCSK9 is important for maintaining cardiovascular health because it is important for the LDL cholesterol disorders. People rapidly translated the gene into therapies. A large number of trials have been performed, and now PCSK9 inhibitors are standard treatment for coronary artery disease prevention, especially if their cholesterol levels are very high. CAR technology also has been used, and there have been phase 1 trials have already begun actually in certain countries of the Western world. CAR technology for treatment of familial hypercholesterolemia are already undergoing trials. So I think these 2 methods are possibly more important methods of treatment.
Thank you, Doctor. That's been really insightful. At this point, Dr. Manish Bansal, how does genomics look into personalized risk assessment? Because that is something everyone would be very interested to understand. Like, is there a way to look at, what is my level of risk? Just because if my parents have had a particular disease, particularly cardiac diseases, does it mean that I have high risk, low risk? Because I may be a girl, does it mean my risk is lower? How does genomics look into personalized risk assessment?
Yeah, genomics plays a very important role here. And in patients who have family history of monogenic disorders. For example, if there is a person whose father had hypertrophic cardiomyopathy, there are very high chances of him or her also developing that disease. So whenever there is family history of monogenic disease or unexplained sudden cardiac death, it becomes very important to screen the remaining family members. And if we find a genetic abnormality, then a cascade screening needs to be done where all the relevant family members are screened clinically as well as genetically. Number two is that if there's a patient who himself or herself has been diagnosed with a condition which has genetic basis, like hypertrophic cardiomyopathy, I'll take the same example again. So in that person also, we need to do genetic testing for two main reasons. One is that by doing gene testing, we will be able to confirm the diagnosis and also assess prognosis, because there are some genes which are associated with more dangerous variants. There are some which are milder forms of the abnormalities. And secondly, once we identify abnormal gene in that particular person, it allows us to screen his next generation, which otherwise would have been very, very difficult. So if someone has very high cholesterol or has this cardiac muscle disease, and we identify the gene, we test his children for the same, and if we don't find that gene in them, then we can be rest assured that they are not going to develop that disease. So that is one way. And second, as we've been talking about polygenic risk score for diabetes and hypertension and coronary disease, so that is a field which is evolving. For example, if I were to find out whether I have genetic propensity to develop heart attacks in future, I might do a polygenic risk score. How it will help me, how I have to take action on that, who all need to undergo that kind of screening, all that is currently in evolution.
Thank you, doctor. So I think there are very clear indicators that if there is an incidence of a genetic component of disease, especially cardiac disease, it is very important to go for tests for the child to make sure that the child doesn't have to go into medication earlier on. So it's a very, very useful screening test. The second being that, when you have diseases that are a combination of genetics and environmental factors, such genomics-based tests will help you understand what is your propensity, and therefore you are able to prevent it better by making required lifestyle choices. So thank you so much, Dr. Bansal. At this point, Dr. Vedam, a very large, vast topic. What are the latest developments in the field of cardiogenomics? So if you could give us the whole bit of it, that will be really helpful.
Yeah, so I will just recall what Dr. Rajiv has also mentioned. So from the time of Human Genome Project, there has been dramatic developments in the tech side as to how we decode the genomes of individuals. So if you look at Human Genome Project done about 25 years back, it costed $1 billion to sequence one human genome. So today the tech is available where you can do it at less than $1,000. Okay, even though it's still expensive for normal common Indian, but still the pace with which the costs are coming down dramatically, which defies the Moore's law. There is a significant drop in the cost. So because of drop in the cost, there are various advances that are happening, not only just at the level of clinic, but also at the level of science and R&D. More and more genes are being identified which cause these diseases. So there is a large database called OMIM database, Online Mendelian Inheritance of Man, where almost every year, anywhere between 500 to 600 new genes are being added. So when the vast amount of knowledge comes up and you apply that knowledge with the advances in the technology at the clinic level, there are different types of tests that are done today, which have become, in fact, first-tier tests. That we call the most common test that is done for monogenic diseases in India. We call it as exome sequencing, where you sequence those genes which create proteins, and you identify those variations which cause those diseases and identify them. And it's a sort of a needle in haystack, where you get a lot of variations, you identify that one mutation which causes the disease. And whole genome sequencing, we expect in the next 5 to 6 years in countries like India, which will become as one of the common tests that will be done as the cost will come down, where you sequence a complete human genome and to identify not only just one variation, but multiple variations in the genome, which will as a causal for not only just one disease, but multiple diseases, and you identify it. So this is a era of biology, era of genomes, where you dissect, you understand, and take it to the clinic level, and also therapeutic interventions are also evolving fast.
Doctor, if I may add a further question to that, I mean, when
Yep.
it comes to cardiogenomics,
Yep.
what about therapeutic interventions? How have they, developed?
So there are a lot of trials going on in clinical trials in advanced stages, as Dr. Rajiv mentioned. Apart from PCSK9 inhibitors, there are what we call CRISPR-Cas9 therapies. There are single base editing therapies that are going on. There are companies like Verve Therapeutics in US where they're trying to edit the genome at a one organ level. For example, they're trying to edit genes in liver so that the cholesterol metabolism and cholesterol synthesis completely changes, especially those individuals who have super high cholesterols, and mitigate the risk of coronary artery disease. There are trials going on hypercholesteremia. There are trials going on hypertrophic cardiomyopathy. And several of these things are in advanced stages, advanced trials, and we expect in the next 3 to 4 years these gene-based therapies come into the clinic.
Thank you so much. I think the big takeaway is that the costs are much lower. What used to cost $1 million is now $1,000, and it's going to be much lesser, which means it's going to have a huge impact on each one of us. And I really like the part where 500 to 600 genes are getting identified every month or so, and more genes are getting added on. And that means, you are in the process of easily identifying needles in haystacks. And based on this identification, various therapies are being created. So thank you so much, Doctor. Now the question is to Dr. Rajiv Gupta. When it comes to prevalence of congenital cardiac conditions in India, is it high? And in case of high incidence, what are the factors behind this? And how does genomics play a role, Dr. Rajiv?
So congenital heart disease, I think, is a very specialized area of cardiology, where not much has been done as far as the genetic analysis are concerned. There are certain syndromes which are gene-driven syndromes, which are there, but the prevalence is only 1 in 100,000 to 1 in a million. So they're not very common disorders. The commonest disorder, for example, hole in the heart or ventricular defect or atrial defects or the ductus and these things, they are polygenic. They are not single gene disorders. So we don't know really anything about those genetics. And anyway, even if we know genetics, we can't do anything to prevent. The commonest cause of gene disorders or congenital heart disease in India, one, people attribute it to malnutrition. Maternal malnutrition and the fetal malnutrition can predispose to congenital heart disease, number one. Number two, exposure to radiation, which also is quite common in our country, can also predispose to them. Thirdly, there are certain environmental toxins which can predispose to congenital heart disease. So I think it's a combination of not only genes, but genes and environment, which has to be very. So we are living in a clean environment, having lots of healthy food, preventing pollution, preventing tobacco, preventing alcohol. If you do all these things, then the incidence of congenital heart disease will surely come down. It's not as high as coronary artery disease, which is very, very common. The lifetime risk of coronary artery disease is almost 30 to 40%. A person born now, almost 40% chances that he'll develop heart disease in the next over his lifetime. So it's extremely high risk. Congenital heart disease, on the other hand, are not so common as coronary artery diseases.
Doctor, if I may just add a follow-up question. So when it comes to coronary heart diseases, can you give us some insights on how genomics play a role? Maybe in prevention, maybe in treatment, diagnosis, screening?
So I think technology is evolving, and we have now lots of ways to identify the risk of coronary artery disease. And the polygenic risk scores is, I think, the latest in the whole cycle. Now, there is an upside to it that if you know that you are going to develop a disease in the next 30 or 40 years, you can take preventive actions now. And there have been trials which have shown that if you lead a very healthy lifestyle, that means walking or exercising almost 40 to 1 hour every day, healthy food, fruits, legumes, nuts, dairy products, and vegetables, if you consume lots of it, you do sort of muscle training exercises, That also helps. And then you have to avoid smoking and unhealthy foods. So if you do all these healthy stuff, then it is likely that you can delay the onset of the disease by 20 years or 30 years. Now that's possible. But the downside is if a person has low risk of heart disease and he thinks that I am okay, nothing to worry, I will never get heart disease. So there is a downside of genetic estimation. Even in the low risk population, if he leads a bad lifestyle, if he smokes, if he drinks, if he doesn't follow a healthy diet, it's very likely that he will develop heart disease. So low risk score is not a guarantee that you will never get heart disease. High risk score is sort of a predictor. Yes, you will likely to get heart disease, so take precautions. So I think precautions are important. Drug therapy is also coming in, but I will not talk about that. I will focus mainly on the healthy lifestyle, which has to be started from very childhood and to be tracked, to be done across the lifespan.
Thank you, Dr. Rajiv. I really like the point where you took upon about people who do not seem to have a risk at the moment. And I'm sure all of us have seen the case where when there is a screening coming up, the patient or the client would be working hard, making sure the diet is good, etc. And as soon as the results are out and they are fine, they go into a binge. So thank you for bringing that point that, it doesn't, just because your screening says that you're healthy, it doesn't mean that you can let it go. It still means that you are responsible for your health, but then kudos for clearing the screening. So thank you so much, Dr. Rajiv. At this point, going a bit more personalized, Dr. Manish Bansal, how does genomics support customized or personalized medications? If you could give us insights both into therapies as well as into lifestyle interventions, that would be extremely helpful.
You see, as Dr. Gupta mentioned, Dr. Ramprasad also mentioned, if there is, suppose we do polygenic risk score in an individual, and if we find that the risk is high, then this risk can be modulated through lifestyle intervention. Studies have shown that it is not a fixed or unchangeable risk imparted by genetics. It can be modified. So in a person who's found to be having elevated genetic risk, I would be more aggressive with risk factor prevention, maybe lower threshold for statin, the drug which helps to reduce the risk of coronary disease. That is one. In patients who got monogenic disorders, in them we cannot prevent disease at present in most of the cases, but we can detect it early, and we can then institute appropriate treatments to prevent its progression, and more importantly, prevent the adverse events that may arise. So, for example, in case of hypertrophic cardiomyopathy, there is a risk of sudden cardiac death. So, in those who are at higher risk of having sudden cardiac death, we can do proper screening and we can do proper interventions like implantation of defibrillators or appropriate medical therapy to prevent those episodes of sudden cardiac death. So, genetics can definitely play a very important role in preventing adverse events. And the magnitude of the benefit will depend on the role of genetics in the causation of that disease.
A small follow-up question here. If you could help us understand, what would those, genomics, therapies and lifestyle interventions based on genomic understanding, what would they look like?
See, lifestyle intervention is going to remain same, regardless of the genetic risk score, in the sense the character of lifestyle intervention. So it's going to be healthy eating, regular exercise. By healthy eating, I would say avoid sugar and extra salt. We've had too much focus on fat, but sugar and excess salt are more harmful than fat. Avoid smoking, minimize stress, engage in regular exercise. So those would be the main lifestyle interventions that I would focus on, and that will remain same regardless of the genetic score findings. The intensity will vary according to the risk.
Right. Thank you so much. I mean, the reason for that question was that, because very recently I came across a article where, depending on the person's score, some were recommended cardio and intensive exercises, some were suggested to do maybe yoga, etc. So I was wondering if there is like the hardcore personalization in terms of therapies as well as lifestyle intervention. So that was the reason. Thank you, Dr. Manish. And if I may, Dr. Vedam Ram Prasad, what are the potential genetic markers for genetic cardiac ailments?
Well, depends on there are a lot of genes, more than about 500 to 600 genes, depending on the disease what you look at. For example, hypertrophic cardiomyopathy has at least about 15 to 17 genes which are there. So dilated cardiomyopathy has channelopathies, there's a Brugada syndrome, there's one gene. There's a different diseases have different genes and which pathway they are involved. Hypercholesteremia, there are several genes which play. LDLR is one of the top gene which comes there. So it all depends upon which gene we are talking. Even in monogenic diseases, the mutations in different genes cause the same kind of a disease also. And adding to one point here is the drug responses also vary depending upon the genetic variations individuals have. The classic example being the CYP2C19, there is a gene where the variations in this gene will make the drug response different. There is a common drug which you call clopidogrel, which is given as an antiplatelet drug, given predominantly for individuals who undergo the stenting process. And for them, this is a drug that's given for lifelong. And if these variations are what we call poor metabolizers, or their drug is not metabolized by the genes and proteins that are there in the body, and the prodrug is not converted into true drug, so it will not act properly. So the dosages change depending upon these variations. And interesting is majority of the Indians and South Asians have poor metabolizer variations in CYP2C19. So they have to move, either dosage has to be changed or they have to change into a different drug. And this is becoming increasingly important, and there are international guidelines for not only just cardiometabolic drugs but also for diabetes and various drugs which are becoming predominant. And we have seen situations where if it's extremely poor metabolizer, there is a restenosis happens in these patients and they come up with more implications at the heart. So these needs to be considered at the treatment level, and these are different genes again for drug responses for different drugs which are present. And the knowledge is very important, and clinicians are understanding and also implementing this at the clinic level at different situations.
Thank you, Dr. Vedam. You have really touched upon, personalized medication with the inputs from the genetic component. What about, if I may just pose that question once again to you, when it comes to other therapies and lifestyle interventions based on the genetic component of a person coming in, would there be different recommendations? How real is personalized medicine and personalized intervention now?
So the drug interventions for common diseases like coronary artery disease, they are not still in recommendation, they're still in guidelines. There are several studies, longitudinal studies have been done. They have shown impact of certain drugs like Dr. Manish mentioned, statins and a few others, which are more beneficial for high-risk individuals, but these are purely research studies. While they are done very well, but they're still not clinical trials. They're not double-blind randomized clinical trials to be taken in clinic. They will take some time. But lifestyle interventions, it's proven beyond doubt, more beneficial in high-risk individuals, but at the same time, we can't negate them in average risk individuals. For every individual, the healthy diet, lifestyle interventions are extremely important and can be personalized. It depends on what kind of food you eat, where you are living, what kind of work you do. It depends. But again, we cannot go and do some kind of a drastic interventions. We need to be careful, and certain interventions you need to follow the physicians and clinicians' advice rather than doing the self medications or doing interventions on your own.
Thank you, Dr. Vedam. I think, yes, we have to listen to the experts, and we have to wait till we have absolutely strong clinical findings on how we can incorporate genetic, information, and when it comes to medication and therapies and interventions. So thank you so much, Dr. Vedam. At this point, Dr. Rajiv Gupta, what is the significance of preventive care when it comes to cardiovascular diseases?
So I think preventive care is of two types. The first type is prevention of the events from happening. This is known as primary prevention. So primary prevention, the standard thing is you want to control risk factors. So for that, we already have evidences that smoking or tobacco is the number one enemy. Number two is the lack of physical activity, lack of physical exercise. We lead a sedentary lifestyle. So I think we have clear recommendations from various international organizations that walking at least 30 to 40 minutes every day is the thing recommended. The third is about healthy food. We already talked about the healthy food and unhealthy foods, which we need to focus on. The fourth risk factor is alcohol, which is, I think, a very important risk factor because the way drinks are taken in India as a binge drinking is very, very harmful. The fifth is pollution, and I think pollution as emerging is a very important risk factor. Not only the environmental pollution, but what we think important is the indoor pollution. And indoor pollution is killing women. This we have to be very careful about because pollution in the kitchen, which are poorly ventilated, tend to produce coronary artery disease. So I think indoor pollution is important. So all these things are pollution for risk factors. But then as we come to risk factors, which are we know standard 4 or 5 risk factors. Number one is cholesterol or the LDL cholesterol, which is the most important risk factor. Now we have strategies beyond diet, using drugs, very, very inexpensive medication to control it. Now that's where genetics can guide us. If we are a high risk person, high gene risk, we give them high dose of lipid lowering drugs. If there is a low risk, we give them a slightly lower dose of the lipid lowering drugs for primary prevention. Secondly is blood pressure control. Again, important because blood pressure almost, a recent ICMR study is showing almost 300 million, 30 crore people in India living with hypertension. So I think it's a huge number. And again, the targets will vary depending on risk. Ideal blood pressure less than 120 over 80. Acceptable in patients with hypertension, the target is 130/85. So 130 is systolic, 85 diastolic. Blood pressure should be less than this. And of course, everybody should be on some sort of therapy, either salt control or weight control or drugs. So I think there's number 2 risk factor. Number 3 is diabetes. And diabetes again is a very important risk factor in our country. Almost 110 million people with diabetes in our country. So we need to be very careful about sugar, about starch, about unrefined carbohydrates, which predispose to diabetes. We have to be careful about exercise to prevent diabetes. And if there's diabetes, we need to have proper control of diabetes. I mean, patients normally say they take drugs for 2 months or 3 months, and then they give a gap for 2 or 3 months, and they say everything is all right. Why should I take drugs? And they land into complications. So I think that sort of a behavior is very harmful, both in diabetes and hypertension and in cholesterol. Intermittent therapy does not work. Everybody has to realize that this is a lifelong commitment. So preventive cardiology is a lifelong commitment to prevent heart disease. And one of the fathers of cardiology, Dr. Convenor, clearly says in a recent editorial, he said that there is no question that we can live to 100 years. If we live well, if we live healthy, everybody should be able to live to 100 years. And the beauty of the preventive cardiology is that you prevent heart disease by all these measures, by healthy lifestyles. That way, you not only prevent heart disease, you also prevent cancers, you also prevent dementia, you also prevent chronic lung disease, chronic liver disease. So preventive cardiology, I think, is the backbone of all prevention. And if we want to live to 100 years, we need to follow preventive cardiology.
Just to add on to that, Dr. Jeremias Tamler, the father of preventive cardiology, he lived on to be 102, and I think he's done some remarkable work in making us understand how we are responsible for our health. And just to add on to one point which I personally love, apart from environmental factors, when it comes to lifestyle factor, the importance of sleep in improving, or rather reducing the incidence of CVD. So thank you so much, Dr. Rajiv. And at this point, I have a question to Dr. Dr. Manish Bansal. Dr. Manish, the common understanding of genetic diseases or diseases which have a component from the genetic pattern is that if I have it, or if my father has this disease or my mother has this disease, I am definitely going to have it and there is nothing that can change it. So in such a belief system, how can lifestyle modification change the way our genes behave and how it can reduce the risk of heart diseases?
You see, if we talk of monogenic disorders, then lifestyle changes are unlikely to impact the expression of those disorders. But it's not true that every person whose family member has first degree relative has a monogenic disorder is going to have that disease, because first that person may not inherit that gene. Then all the genes don't have 100% penetration, which means that even if the gene is there, it may not result in a disease. And then even if disease develops, it may not be severe enough. So it's not that if there is a gene in the family, you need to be that worried that everything is doomed. That's not so. However, as far as I understand, I don't think by lifestyle intervention we can make too much impact on the expression of that gene in the next generation. So that is something which we will have to accept and take appropriate measures accordingly.
Thank you so much, Doctor. As we conclude this engaging session on genomics and cardiac health, latest advancements and preventive measures, we from the Times of India express our heartfelt gratitude to our panelists for their illuminating insights into the world of genomics and cardiac health. I thank Dr. Vedam Ram Prasad, Dr. Rajiv Gupta, and Dr. Manish Bunel. We are grateful for their expertise and dedication to advancing our understanding of the heart health. We would like to extend an invitation to our viewers to join us at the TOI World Heart Day Symposium 2023, Every Beat Counts, where we have more profound discussions on heart health. Thank you for being part of this enlightening symposium. Until next time, may every beat of your heart count towards a healthier life. Thank you.